Well, very good morning, everybody. Firstly, I want to take this opportunity in thanking the Cancer Association, in particular Sue Jens van Rensburg and Dr. Albrecht, for inviting me here. It's the first time I've been the first speaker at a conference, so I don't know whether it's a good thing or a bad thing. I've decided when I was approached and asked to provide a topic, I thought very long and hard about it. Cancer in the home. You know, when people are diagnosed, patients are diagnosed with cancer, it affects the home. One cannot remove the patient from the surrounding. It affects the entire family. And a home is made up of family. And so that was my thinking behind it. And why esophageal cancer? Because it is one of the most common cancers amongst females as well in certain areas within South Africa, and you'll hear me talk about it. So I figured that let me talk about it, but at the same time, let us reappraise the evidence as we see it. As we stand today and we reflect, let us see what we have done in South Africa, how far we've come, whether we've achieved what we set out to do, what we need to do in future, okay, what we don't have to do anymore, okay. So the idea is to rethink the approach that we've undertaken over the last 50 some odd years into this into research into esophageal cancer, and I want this to be a platform that helps us all to question, discuss, and debate. The idea behind it is for all of us to leave here enlightened, so that as scientists we can go back and explore new avenues, okay? And this is what makes science one of humanity's most outstanding methods of inquiry, to question, discuss, and debate. So it is with this mindset that I present to you the topic today, which is esophageal cancer in South Africa, a reappraisal of the evidence. So, firstly, some gory pictures. Why is it such a bad tumor? Well, firstly, it is, in terms of the world, it's the 8th most common cancer, with a very wide geographical incidence in terms of geographical variation in terms of incidence and mortality. So even within South Africa, we have a wide variation in incidence, we have a wide variation in mortality, similarly with other regions of the world. Risk factors may be similar, risk factors may be different, and we will come to that aspect of it as well. In terms of mortality, it is the 4th site that is characterized by poor survival, with survival rates estimated at about 10%. Now you find that with esophageal cancer, most patients present with a condition known as dysphagia. Why is this the case? Well, if one is to look at a normal esophagus, this is what it would look like when you look down into the lumen. Okay, this is an early tumor. Okay, and often patients present with the symptoms with advanced stage of disease, and you can see here that the lumen is closed. So you have total dysphagia, and the patient cannot swallow, and that's when they present. Now, in terms of this cancer, there are 3 areas particularly with high incidence rates. The first being South America, and it's actually the northeast of South America, which is northeastern Argentina, bordering that of southern Brazil, Uruguay, and Paraguay. It is this area here, which there are very high rates that are noted in literature. We have the Asian esophageal cancer belt, which stretches from east of Turkey all the way along the Caspian littoral of Iran, all the way up to northern China, particularly in Lingshan. And then we have the former Transkei region, and this is a fairly old map just to show you the former Transkei region in the northeast region along the Indian Ocean up there. So these are the particular 3 regions of the world that have very high incidence rates of esophageal cancer. And when we look at risk factors for this disease could be very different. Now when we look at risk factors, and often patients ask, what causes cancer? We must bear in mind, we have risk factors which we call, or which we label as sufficient causes, meaning that you only need exposure to that particular risk factor to result in the disease. Like, for example, smoking and lung cancer, okay? You don't need any other cause for lung cancer. But at the same time, not everybody who smokes gets lung cancer, all right? So that is a sufficient cause. What we also have is a necessary cause, all right? Which means that you need a whole host of other risk factors that together, what we call a causal constellation. And it's together with all those risk factors put together, it emanates together as a sufficient cause to result in that particular disease. And as epidemiologists, we try to stratify these as what we term as component causes, necessary or sufficient causes. Okay? So, in reviewing the literature, we went back and looked at studies. Now, often you find there's lots of studies that are done, but often a lot of studies undergo methodological flaws. That when it's time to review these literature, to put together a policy document or any document that summarizes what is going on, you often find that you are faced with methodological issues that perhaps at the time have not been thought of. In South Africa, there have been a few descriptive studies that have been done that have described rates of the disease over time from 1950s up till now. And then we've had ecological studies as well as case control studies. With the case control studies, a lot of these studies have looked at tobacco, alcohol, diet, and so forth. And then with the ecological studies, particularly with regards to mycotoxin exposure and food contamination that we've looked at. But we've also looked at studies and we've seen, well, could the effects that we see in these studies, could they be a result of other biases in the study? For example, misclassification. How were your cases selected? How were the controls selected? Was there any possibility of recall bias? Was there any possibility of interviewer bias? Was there any possibility of selection bias in your cohort? So these are all issues that we've looked at in all of the studies and try to decipher, well, which studies, based on the methodological quality of the study, which were good studies, which were poor studies. And this formed the basis of our appraisal of the evidence. Certainly, when we look at the evidence-based pyramid here, in vitro research is absolutely important. I think it's critical. But when you want to make inference to the population, it is absolutely important to move up. And that's where we lend a lot of support to your case control, your cohort studies, okay, and finally your systematic reviews or your meta-analysis. Because your meta-analysis actually summarizes and pools the evidence together. And that forms the basis for an evidence-based approach. And a lot of the policies emanate from the systematic reviews or meta-analyses because it gives you the best evidence. Okay? So, when we look at esophageal cancer and the early days, right, the first report of esophageal cancer actually being an important public health problem emanated around 1957 by Burrell. Okay? When they began to see a lot of patients in Frey Hospital in East London. And at around 1950, Otto also described that there was a steep increase in esophageal cancer incidence around that time. And what we know from the publication by Rose in 1965, that on average they were seeing about 50 cases a year at Ampata General Hospital. And by that time, there was sufficient evidence to actually indicate that the Butterworth-Kentani region, which is, if one is to look at the old map of the former Transkei, the Butterworth-Kentani region is just down on this end here. The Butterworth-Kentani region became the epicenter for this disease. In fact, from just looking at the notes that what Burrell had written, he had indicated that this disease was not common 25 years prior to his publication. So it was within that 25-year period that suddenly this disease crept up, and in fact it became so common that in Isitosa there was actually a name for it, where people began to diagnose the condition on their own. That's how common it was. Okay? So when one looks at the Eastern Cape province, you can see very peaceful, sparsely populated, rolling grasslands, very peaceful. Yet we always say danger lurks. Okay? So when we look at South Africa as a whole, I've put this up just to set the scene for the rest of the talk. If we look at South Africa, and this I've put in 2003 reports, we could see that nationally, from the National Cancer Registry, if we look at the rates for esophageal cancer in males, okay, 12.6 versus females 5.6. So there's almost a doubling, with males having twice the risk as females. But if we look at the Kentani region, we can see that the male to female ratio almost equals 1:1. And we can look at the rate. The rate is almost 5 times that of the national average, which indicates there's a certain clustering of a very highly susceptible group of individuals within this region. What makes them susceptible? What makes them prone to this disease? And that's what we set to find out.